All right, so for everybody who's on, recording is in progress. It's 9:30 and I don't know if we want to give folks a little more time to jump on or whether or not we need to dive right in.
I would say let's get going. It's we've got a good crowd. We've got 76 folks joined. So.
All righty.
All right. Well, I can take it away. So the purpose of the meeting today is to go over the instructions for a template that we would like to use to collect some information so that we can help. It can help me understand the experience in Sacramento County with the outpatient rates. I should have introduced myself. I'm sorry. I'm Jim Pickett. I work at Optimist. I'm helping the county with a couple different projects on the rates and on some technical assistance. So like I said, I'm going to be sharing a template. I know that I was working with the county to share this template with you all. I'm not sure if that's gone out or not. But if it hasn't, I'll take plenty of time to go through it slowly. It's pretty it's pretty straightforward. There's not a whole lot of elements or features in it, so I can start sharing that. I think there should be plenty of time, so I think we'll have time to answer all questions, and I think that 90 minutes will be more than enough. So with that, I'm going to,
can I just jump in real quick and just ask everybody, there's background noise, and if everybody could mute themselves and when we're doing questions, you can unmute, but for now, if everybody wouldn't mind muting themselves, thank you.
All right. So I'm sharing my screen now. Should be able to see an Excel file with some instructions that I have up. Basically what I'm trying to do, I'll go into the instructions in a minute, but let me just go into one of these tabs, and just for your reference, all of these numbered tabs are really the exact same thing. What I'm trying to do, so I have access to the county's, to the utilization data, the experience that you all have and submit to the county. And I'm trying to associate that data with a number of full-time equivalents that produce those services, which will help give me a line of sight on the overall productivity of the program and where things are at this point, or as of fiscal 24. So let me just step back into the instructions really quick. So so for your agency, what I'm requesting is that you fill out one tab for every program that you have, and so. And you can use as many tabs as you need and leave the others blank. So if you click into here, there's a spot for agency and program. I have a list, which I believe is comprehensive, but if for some reason it's not, I'll touch on that. You program in there, I'd say like, hey, on tab 1, I didn't have anything, so my item wasn't in the drop downs, but this is what it is, and and just leave a note there, and we'll be able to work with that. So yeah, the first step is picking your agency and program. So if you have a few different programs, you would fill out a few different tabs. Back to the instructions. The second step is fill out the yellow cells in the tab. So we already talked about choosing the agency and the program. And then the numbers that we want to collect the actual numbers of employed FTEs, not including any vacant positions that your agency and program employed between July and December of 23. So that's what we would fill into this column, and I'll go through a series of examples to make sure that that's unambiguous. And then finally, we want to fill out the share of full-time equivalents that are associated with Medi-Cal. So my understanding is that sometimes people could be split, maybe serving Medi-Cal, doing Medi-Cal work, maybe sometimes doing other work that's billable either by a different payer or outreach that may have payment associated with it. And so we're going to, in this column, we want to identify just the share which is attributable to Medi-Cal. Let me go through some of these examples, and hopefully that this will clarify the different situations. And once I get through them, we could probably, I think at that point, take questions, and you all could let me know if there's scenarios that you see that I haven't contemplated here. So I start out the examples first with the easiest scenario. So you have a full-time mental health rehab specialist who worked for your agency for all of July through December of 23, and they worked exclusively on Medi-Cal. So that person would be counted as one whole FTE because they were there the whole time, and they work exclusively on Medi-Cal. So their Medi-Cal direct service percentage time is 100%. Now that's not to say that they're 100% productive. So it's not a productivity percentage. It's really just how much of their time is associated with Medi-Cal, whether that time is billable or not. The second example adds just a small layer of complication. So let's say you have a full-time mental health rehab specialist, but they didn't start at your agency until 9/1, and they work throughout the end of the year. Well, so that's 4 out of 6 months. We got little comments here if it's helpful, just rationalizing, why we came to those numbers.
Okay, we're going again.
All right, great. And if there are any kind of errors or hiccups, I'll be happy to, provide extra recording for anything that was missed. So for this example too, the person is 2/3 of an FTE. They're still exclusively working on Medi-Cal, so they're 100% there. So the next scenario here is you have a part-time worker. So they're 30 hours per week part-time, and they work for the entire period, and they work exclusively on Medi-Cal. Well, in that situation, instead of counting them as a full 1 FTE, full-time equivalent, we're counting them in proportion to their part-time status. So they're 30, they work on a 30-hour week out of 40, so that's that's 75% for full-time equivalent. And then there's still 100% Medi-Cal. Let's see, the next scenario is a mental health rehab specialist worked at the agency for all of July through December of 23, but they spent 40% of their time generating non-Medi-Cal revenue, such as Medicare, commercial, other county payments. So that in that situation, we basically would just, if they're doing 40% other things, we would just drop 60% in here for the Medi-Cal direct service time. The next scenario is we had an MHRS working for the agency from July through December, and they worked exclusively on Medi-Cal, but they split their time 70-30 between core and FSP. So on the core tab, they'd be 7/10 of a person, 7/10 of an FTE, and then on the next part of that on the FSP tab, they'd be 0.3 of an FTE. And then, so these were the basic components that I could think of. And then just with the next couple of examples, I just illustrated how, you know, if you had a couple of these scenarios existing at the same time, how you could handle that. So if examples 2 and 3 occurred together, so someone was part-time and they started on 9/1 of 23, you know, they were working for 4 out of 6 months. They're 30 out of 40 hours a week. When you combine both of them, as shown in the comment that I'm highlighting, that would work out to half an FTE. So you basically just multiplying those previous adjustments together. And then a similar idea for the final example where we combine 3, 4, and 5. So someone who's there 4 out of 6 months, they spend 70% of their time on core, and then the combination of that would give you 52.5% of an FTE, and then also 60% time dedicated to Medi-Cal. So that's what I had by way of instructions, just to show different examples, but I'm definitely eager to hear what you all have to say, if there are things that are ambiguous, or if you just have clarifying questions. So I'm going to pause now and take questions.
Yeah, hi. My name is Dwayne. A question for you. The way you just showed how to fill this out, we don't have the ability to do that because the cells are locked.
So the yellow cells should be unlocked.
No, what I mean is, like, you're giving us job titles with one line, but if I have 4 certified nurses, I can't lay it out the way you just described. I would have to bundle everybody into one giant number there. I can't get that granular with your template the way you just showed how to fill it out.
Yeah, I think that with the instructions, I was trying to go for the concept of how an individual person would be added up, and you can definitely do that, like, kind of behind the scenes, and then feed in the final numbers into the template. I don't need a reporting on every individual. So if you have 2 different people and one of them's a full FTE and another one is 3/4, you would just put 1.75 into the line.
Okay, and then it looks like you're only trying to capture people who have worked. What is this data going to inform if it doesn't have cost?
Well, so I'm trying to get costs from other sources. I wanted to ask for the minimum necessary that I didn't have. So I'm working with the county to understand that.
Yeah, thank you. I'm just trying to figure out what this work is going to end up as a final product, because if you're trying to get, like, what the actual units being provided are by taxonomy, wouldn't that already be in SmartCare?
So yes, the actual units provided by taxonomy are in SmartCare. The thing that I can't tell from SmartCare, though, is if there are 100 units of of AOD alcohol and drug counselors, I don't know how many alcohol and drug counselors produce that. Even there's something where I can see that there, like, how many people were effectively providing any services, but I can't tell if they're full-time FTE or part-time or when they started and stopped. So that's the limit on my visibility there.
Okay, thank you.
Yeah, thanks for the questions. Karen?
So I kind of going back to the same questions that were just answered. For LPHAs, so an actual direct service FTE, we have, let's say, program director. They're LPHA, but they have a 0% billing percentage because they don't provide direct services to clients, but they are licensed and they are an LPHA, and they do occur on the on the Exhibit C up in the top portion. So am I excluding management or people who do not direct bill and just including, because from an LPHA can be anywhere from a clinical director to a program director to a clinician. It's very mixed. That's a broad category.
Yeah, that's a great question. So LPHAs or others who provide no direct services, would you say, so are they could they maybe sometimes provide a direct service if there was a need, or is it a situation where they would never provide a direct service kind of no matter what?
Well, I mean, these programs, do whatever it takes. If somebody needs to see a client, they will see a client, but they are supervisors. That's the program director, and their primary responsibility is not. And that's something we kind of negotiated in rates years ago of not giving them a billing responsibility because they are supervising a program with 50 or 60 employees. So that kind of, it's like, well, they're in our definition before, they're in the Exhibit C as an FTE. They're not a direct service FTE, because what you do is you take it's kind of like you've got two elements in there that have always, our direct service FTE already takes into consideration what you have in row D, which is that percentage. So it's kind of a little confusing because we normally have direct service FTEs and then their percentage of billing, and then that comes over to, the direct service. We have the number of FTEs in the program, so they're possibly billable, their percentage of direct service, and then it comes to a direct service FTE. So having this is a little confusing the way it is to me. I don't know to anybody else. And that we do put job titles, and there is quite a bit of a mix, especially in the LPHAs and the MHRSs. There's more, and then, the other qualified practitioners too. So there's a lot of mix of individuals with different percentages. So you can have an OQP that has 50% billing, and you could have one that has a 90% billing. And it depends on what job they are, and they're very, very different jobs, but just grouped into one category.
Yeah, I think we, so let me ask you this. Would it be, because you mentioned the Schedule Cs are filled out in a way such that the LPHA, who's a clinical director, would be counted in the rows amongst the other clinicians? Is that the more intuitive or natural way to report that in Sacramento, like with them kind of all, like with your count of your LPHA, including your clinical director in the row?
Jim, can I ask a question in regards to this dialogue? Because I'm looking at the document itself, and it clarifies at the top that what providers are being asked to complete is actual direct service FTEs. So if I'm hearing Karen correctly, she's identifying individuals who would be classified as an LPHA but are not direct service staff because their role and function is different. They're not doing direct care, rather they're supervising folks. Now, does that mean that they would ever step in and help? That is a potential, but would we then calculate them into this formulary in terms of unit volume for that FTE that's primary responsibility isn't direct care? Am I understanding, Jim, that this formulary is intended to identify your direct billable staff by classification and the percentage of time they'll be doing billing?
Yeah, this template won't, it'll be used in conjunction with the other data that I have to determine the percent of time doing billing. But yeah, the focus is on those who are actually providing service. And as I was thinking about it while you were talking, Kelly, I think that those, like if someone's in a leadership position and they're basically not billing, I would probably exclude them. I'd exclude them from here because it might make it a little bit of an apples and oranges comparison, like going from one agency to another. If an LPHA happens to have a leadership position here, but not over there. So I think that in the way that I think of the rate buildup, a leadership and support personnel is in a separate bucket and should be built up separately. So I think that would probably be the best answer to your question, Karen. But I want to see what your thoughts on, what your reaction to that is.
I think we should exclude management from there, but I think they should be included in the whole picture because the folks who do bill have to carry the load to cover all of those expenses. So their supervisors' expenses, operating, indirect, and be curious where this goes. But know that you're going to get a blended rate because if there's multiple positions in each of the categories, one position will have a different billing percentage than another position. So if I have an employment specialist, they might be at 50%, but in that same category, I have a housing specialist or I have a personal service coordinator, then they're going to have a different billing percentage. So eliminating the job title will give you, and summarizing this is going to give you more of a blended percentage rate rather than something that you can tie. All MRSs are at 90% and all of these are at that. So you're going to get a blended rate.
Yeah, and just to be clear, that would, any kind of blended assessment of the productivity would happen downstream from this as I incorporate actual units, because there's nothing about actual utilization in this template. So it would only be the FTEs, those who are classified as a billable or a direct service worker, and then some percentage of time that they're spending on Medi-Cal. But I understand, Karen, your point that that not all folks are going to have the same role and are going to be billing the same amount. And yeah, so understood.
And there's a question in the chat that just wants from Beverly, wants to make sure that we're clear that we're going to clarify we're going period is through December of 23.
Yeah, thanks for bringing that up. That's definitely worth emphasizing. Yes, July through December of 23 is just what I wanted to look at with regards to, I'm requesting that in the template so that I can match it with a July through December period of utilization data. I wanted to cut it off after December so that I could have some time for run out and make sure that the data is more complete. I see another question that came through the chat. If we have a staff that worked 7-1 to 10-1, we would exclude them from the survey. Great question. The answer is no. You would include them in the survey. They would get, they would be half an FTE because they were present for 3 months in the period.
If we have multiple contracts, so not just Sacramento County, do we allocate our staff just for what they do for Sacramento County or as our total structure and how our company is set up?
So you have direct service workers who are providing service in multiple counties.
Correct. So we'll have X amount in Sac County, X amount in Solano, X amount in Placer. So do you want just what we do for Sac?
Yeah, exactly. So if they spend half their time in Sacramento and half their time in Placer, then you'd count them as half an FTE.
Got it. Thank you.
Oh, Karen?
Thanks. So we're giving you this first piece of information. Are there going to be follow-up pieces where we can review the units of service tied to the individuals or tied to the categories and be able to put in our operating expenses and so forth? Or is this going to be done outside of our site or participation?
Well, the way that it would, I'm going to have to talk with Kelly about that, just to, you know, with appreciation for the timeline and the nature of rate setting, where we would have to group up data with each other. So like, you know, across some providers. So yeah, so I'm going to take that offline and talk with Kelly about that.
Yeah, because I for one would really feel uncomfortable if we were not able to participate in putting all of our numbers together, because then we're not able to validate those numbers. We're not able to really fully participate, and we were asked to fully participate in this. And we are, I know a bunch of us that talk are ready and want this to be really successful. And so I think it's, you know, as the accountants, we really want to be able to participate and or review or analyze our information that's being used.
Understood. I'll go, I've got a few hands raised. I'll just go from top to bottom of my screen. Angel. Oh, I just lost you.
Oh, there you go.
Okay.
All right, so I understand the groupings of that. One thing I'm a little unclear, our rates, our original rates that we have are based on Medi-Cal and non-Medi-Cal rates. Is this report saying that whatever is not in Medi-Cal, that we are doing non-Medi-Cal work to equal 100% of that type?
Let me make sure I understand your question. You said that currently your rates are based on Medi-Cal and non-Medi-Cal. So are you saying that the rates that you receive for Medi-Cal incorporates information or data from your non-Medi-Cal services?
No, it's like our service coordinators can bill Medi-Cal services as well as non-Medi-Cal services. And those are two completely different rates depending on the service they provide. So in this report, I just want to make sure that there is other type of time that they are here, that they do travel documentation, whatnot. So I just want to make sure it's not overstated that whatever is not Medi-Cal, that it doesn't just all go to non-Medi-Cal direct services, because that would also be a statement of productivity.
But let me restate and make sure that I have got it. So so if we had a person in one of these categories and they were, you know, one person and maybe like 70% Medi-Cal, so that one person, 70% of that one person would then be compared against the utilization that was being generated for that particular category, with the understanding that it's not going to equal like 70% of 6 months of an FTE, you know, because they are, to your point, are going to have the travel time and documentation and other things that are going to bring productivity down significantly. So yeah, we would account for that there's and in fact that would be what we would be measuring from, like, kind of using this and the smart care data. But I just want to make sure I'm tracking with your point. So
Jim, can I just jump in and just
Yeah.
see if and Hal, see if I got this right? So we have, of that FTE, we're asking the provider to calculate the percentage of their time they're going to be billing Medi-Cal services. And then additionally, we have local Sacramento County codes that's reimbursed by local funding at a different rate. So if I have an MHRS that is doing a combination of Medi-Cal services and engagement or other types of services that draws down local funding only, no Medi-Cal, but that is part of that productivity or that percentage of time for that employee. How is that captured in this spreadsheet? How did I do, Angel?
It's kind of accounted for, it's kind of for the full time in both categories, and there's no room for that other section. That's correct.
You did great, Kelly.
So all right, Kelly, you were mentioning that there are some county codes and whatnot. So I'm sorry, I might still be missing something. Can you say it again?
Yeah, absolutely. And I think some of the documents you've looked at shows that there's two columns. There's the direct care staff, and then the percentage of their time they're going to be drawing down Medi-Cal billable services, and understanding what that looks like in terms of building the Medi-Cal rates. Then for non-Medi-Cal services that our providers are contracted to deliver, they get reimbursed 100% with local dollars for those services. But that's a percentage of the time that their direct care staff are spending doing the complement of services. So the question I heard Angel ask is, how is that then captured? If I have 100% of an FTE, that percentage of their time we're calculating is about 30% of their time is doing these other non-Medi-Cal services, and about 70% of their time is doing these Medi-Cal services. And we want to make sure we're calculating that, but it's what Angel was saying, it's different rates. So if you get $1 for Medi-Cal, and don't quote me on this, it's like 80% for non-Medi-Cal, something along those lines.
That's good to understand, that if there is a rate differential. I think that, the way that I was generally thinking of it is that, the rates have to stand on their own. So if we're building up a rate for Medi-Cal, that would, kind of correspond to the share of time that you're spending on Medi-Cal, billable or non-billable, because there's both, and the rate has to cover everything. And that one program shouldn't subsidize another program. But is the implication there that some programs are underfunded or not as rich as the Medi-Cal payment, like for the same service provided?
So it's not two different programs. It's just how the array of services are compensated. So it's same program. It's the full array of services. Some are Medi-Cal billable and some are not. So we want to make sure we're paying providers for the services that we can't bill Medi-Cal for. But this is a Medi-Cal program, so we want to make sure the rates for Medi-Cal are substantial, and just recognizing we want to reimburse providers for all the other services that help people through the recovery. So that's how it was designed last year. That was the concept.
Okay, got it. So the county is kind of filling in the gap at a discounted rate for certain services that are not Medi-Cal billable. I'm not sure how big that is compared to the Medi-Cal services. I think that the easiest way to fill this out would be to still kind of focus on the time differential, how much time is being spent on Medi-Cal versus non-Medi-Cal. And if there's anything that I need to be considering kind of on the back end with regards to the non-Medi-Cal services and how much they pay and whatnot, then that's something I think that I'd need to talk with you further about, Kelly.
Yeah, it might be worth adding a percent of the FTE time spent doing MHSA, because some of our, or not MHSA, but non-Medi-Cal services, because some of our contracts spend more time on that than others, and it could be an important variable to consider because it limits the amount of time available for other activities, if that makes sense.
Okay. So you're suggesting adding in something to indicate like MHSA funding or like a different category, just to make sure I'm
Yeah,
tracking.
the estimated amount of time that a staff class spends doing non-Medi-Cal services, and those non-Medi-Cal services are needed to help folks through their recovery journey, but they're not a Medi-Cal service, but they might spend 8% of their time on a weekly basis doing those non-Medi-Cal services. So they are being productive, just not on the Medi-Cal side.
Yep. Right. So we'll have tracked that, and no suggestion that that wouldn't be productive time there.
Right, on the Medi-Cal side, yeah.
On the not, we'll track the non-Medi-Cal and time as well.
Got it, yeah.
Lakshmi?
Yes, I just wanted to add, besides documentation time and travel time not being billable, there are a lot of non-billable services that our staff have to do, which kind of falls under administrative, what they consider administrative tasks. And one of the challenges we have, we can't just assign it to a staff person because many of these tasks are language and culturally specific. We serve API communities, so our clients speak 20 to 25 different languages. So it has to be more direct staff specific. And so that comes under, you will see a lot of our staff doing non-billable service notes. They have to enter those notes, but those are non-billable. So that also lowers their productivity in kind of sense they are not doing billable services. And the other thing I want to mention, and you may know this, Jim, because when Smart Care was rolled out, for those of us who use Smart Care, the ramp up was very, very, I would say at least 4 months. And even to this day, there are a lot of changes, etc. So every week they had to do something different, or they were told what it had did last week was not the same as what needs to be done again. So there, I would say that 3 to 4 months for my staff, the productivity is not really indicative of what they are capable of. Now, I know some of our other providers have their own EHR, so their staff had that familiarity, whereas our staff had to be changing, etc. And then for our supervisors, etc., once in a while, you will see them having notes. So when you look at names, you may see a supervisor's name come up in productivity because they may have had a crisis intervention note or maybe a treatment team consultation note, but they are really not direct service staff, but they have that overarching responsibility to enter a note to kind of address a case or a certain situation.
Yeah, thanks for the comment. So on that last one for the supervisor, I'd say as long as you don't include them in here, we'll be able to neutralize that problem. So that'll be okay. Definitely have heard of some issues with smart care. So understand what you're talking about there for the initial 3 to 4 months. I definitely welcome you to add kind of any commentary that you'd like to into here to give that kind of color on it, because I definitely know that, a point in time, using this information at a point in time when it's such a dynamic time too, when it's not even like, okay, the program's been running for 5 years like this, it's that there's a lot of limitations on that. And, so we're trying to make the best out of what we can. And, but I think that kind of commentary about, about productivity, about anything else that you want to share, we definitely welcome that, and we'll try to make the best use of it we can. You're welcome. And the first comment that you made was around some non-billable language services. I do think that maybe a lot of the services, if they relate to the travel or the documentation, might not be billable. I do think that there are some language add-on codes for those who are providing service that could charge an add-on, which could be beneficial. But that's also good context if if some organizations have unique costs that might be hard for me to appreciate. So I definitely encourage putting that into the comments as well.
I will. Thank you, Jim.
Thank you. Linda? Oh, sorry. Did someone try to jump in? Oh, okay. Sorry. Linda?
Thank you for recording this. I see probably going to watch it a few more times. So one of my questions is, if we already submitted this report and we're understanding things a little bit differently, one, can we resubmit, and what would be that time frame?
Have you had time to get this report? I thought it just went out, but I don't know.
Well, this is one that this is the sorry, one that we completed last year. I think it was maybe it was January. So
oh, okay. I think that this will definitely be a different perspective than that other one. One of the things which I think is different is our take on vacancies. We do not want to be reporting those vacancies. We want to see the people who are actually there, actually providing the service. I think that'll give us a better read on, on productivity, and that I think that, like, from a rate setting perspective, for me, the contract amounts, which are kind of tied to those vacancies, that's just less relevant than the actual, like, what actually happened during the period. So I do think you would need to resubmit. Yeah.
Do you know the time frame, or maybe that's too early? When would you like to see this report submitted? What's the deadline?
Well, I'm not sure, Sacramento, if you all have sent anything with the deadline on it. I'm trying to keep it minimal so that I could get it fast, because of just where we are in the fiscal year prior to the next fiscal year. So I don't know if it's possible to get it back in a week for just FTE reporting like this, but that would be my preference.
Okay, thank you.
And I just wanted to raise the issue that with the implementation of smart care, this is a little different than Lakshmi's comment, but there's still, for those of us who use a separate EHR, there still appears to be some discrepancy between units of service delivered between the two systems. And so I would, there may be a need to reconcile, or have some of us who have a separate EHR provide you with what we believe our units of service delivered are versus what's been delivered or shows up in Smart Care.
That's really good to know. Can you characterize how they're different? Does Smart Care tend to overstate it or understate it?
We'll have to provide you with that detail after this meeting. I just raised the issue. And we're a provider in multiple counties, and this is a common issue with Smart Care.
Okay.
There is not currently interoperability between Smart Care and other EHRs. And so you do run the risk particularly if there's manual data entry that has to occur.
Yeah, I'm very interested in hearing about that, because that's obviously we want to make sure that the data that we're looking at is materially right. So yeah, please do follow up on that. Angel?
I think along the same lines, so this percentages that you're asking for, there really isn't a clean way from SmartCare to give us that, to compare it to our own paid hours. So is that the percentage you're asking for? Like the hours that we pay an employee classification against the time that SmartCare provides? Is that what you're asking us, that percentage?
It's the time that Smart Care provides. So I'm not going to be, I'd only use Smart Care for the actual units that are being billed, not for determining how much, whether an employee was there for some period of time. So I'm not sure if the FTE information that you would pull would have to come out of Smart Care, or if it would be more just on your end saying okay, I know that I had these people, here's when they started working and stopped working, and some of the people maybe split their time between programs. I'm not sure if that's rigorously tracked. If not, if you have a best estimate for how they split between core and FSP, as long as it, I would say do your best there, as long as that totals back to the actual full-time equivalents that you had for the period, that would be an okay way to deal with it.
Okay. Yeah, because those are two completely different concepts. Like if we look at our employees' time and attendance, that time as a percentage would be different if we just say, let's run all of the direct services that Smart Care provides and the staffing, and then that's the FTE. That's a completely different number. So which way would be best for you?
So maybe an example would help, just to make sure I'm picking this up right. But if you had an employee and they were working full time,
Yep.
and so and they were working for the whole time, I'd want you to include them in here as a full FTE, regardless of what Smart Care, how that would report it out.
Okay, so time from our time and attendance. So whatever we paid that employee.
Right. If they got 6 full months of wages, they're full FTE. Yeah.
And then if they had, a couple weeks training that,
that's still time they're working.
They have to ramp up, it'll still just be that.
Yeah, we've got to, that's part of the natural process.
Okay.
And we've got to make sure that's all baked into the numbers. To Lakshmi's question, you can feel free to give additional context if you think anything is necessary in the overall, in the instructions tab, but I understand that people come and go, and there's training time and ramp up time, and probably a comment's not necessary unless it's an inordinate or highly unusual period. I would probably, so training and all that, that's paid time. They're an FTE during that time.
Okay. All right. Yeah, that matching, I don't think there's a clean way to do it right now. I think it's going to be some work, at least for us, to match those together, to get the groupings then together.
Yep. Karen? Looks like Karen may have stepped away. Deanna?
Hi, Jim. So it sounds to me like we are not looking for productivity percentage. I heard you when you said that. I think that the real confusion for maybe folks that are only serving Sacramento County and only have a Sacramento County contract, breaking it out between Medi-Cal and non-Medi-Cal is where it gets sticky. But those things are already listed in our contracts and on our invoices. So I think for this purpose, it may be easier for us to gather how many full-time employees we're devoting to Sacramento County, and then possibly Sacramento County bringing back, okay, it looks like we have 80% Medi-Cal, because non-Medi-Cal is just folks that are not Medi-Cal eligible, usually. Sometimes there are other services that we built that's not in Medi-Cal, but I mean, majority of it is for folks that are not Medi-Cal eligible. We're using alternative Sacramento County funding, but we're still devoting that time to Sacramento County. They're still a full-time employee.
Okay, let me parrot that back to make sure I got it all right. So this column is easier, more manageable to fill out. This column, you may want me to get some of that information from Sacramento. They might be able to report that better. And generally, this column is just people who, for whatever reason, don't qualify for Medicaid, Medi-Cal. You're getting paid directly from the county. They're not like commercial or Medicare members.
Right.
Okay. Yeah, I mean, definitely note in the comments if like, I can take that back in talking with the county about this column, but if you have an estimate that you can try to fill out, please do. And if you want to put any kind of caveats or uncertainty in there, please add that into the instructions. All right, Karen, I see you're back.
Yeah, sorry for the interruption. I just wanted to clarify on the actual direct service FTEs. I've had to do this for I put this together for another analysis. And what we did was take the total paid hours, divided that by 1,040, which was a half year. And that came out to the number of FTEs. So whether a person worked or was on vacation, that was the total paid hours. And that came up with the FTE. Is that what you're looking for?
Yeah, I think that would definitely give a reasonable approximation if that's the way that the data is stored in your systems. Like, I know that 2080 hours is a typical work year. 52 weeks a year times 40 hours a week. If you do that, you might get like, 1.05 FTEs when really you had one FTE there, and it's just reflecting the fact that, well, July through December has a couple more days in it than January through June. I'm not particularly worried about that level of like discrepancy between like you've got 1.03 FTEs instead of one FTE. So if it's an approach that reasonably gets back to the count of full people that you had there for the year, then I'm okay with that. Or for the 6-month period, as it were.
Yeah, I mean, that's it for us. The only way to really pull that up in any kind of expedient manner is to run the reports through payroll, look at total paid hours divided by that to give you, then you have to categorize people by job descriptions into the provider type. So there is a bunch of going around that and then eliminate the people. Now you want me to eliminate the people who they're in the program, but they don't provide direct services like PD, eliminate those FTEs from there. So I don't know, for consistent data, if we had more specific instructions on how to pull it, you might get a better, because everybody's doing a little bit differently, guesstimating by months and so forth, instead of looking at actual hours. I don't know how comparable the data is going to be.
I guess I would think it should be pretty comparable, because if we did the July through December and took those actual number of days, I know that there are 180 84 days in the second half of the year, 181 in the first. So it would be like just a slight difference there. I'm hesitant to be too prescriptive just because I don't know if your systems are aligning with other systems and if that hours method is going to work for everybody. But I'm definitely okay with it. You know, that seems like that would get you pretty close to what we're looking for. And I'm also okay with it if someone else says, you know, I've got, you know, this number of people and I'm going to count them as they were there the whole time. I'm going to count them as an even 1.0.
Thank you.
Yeah, thank you for the questions. Let me see if there's any new questions in the chat. Deanna, was this one that you already asked or is this a new one?
Yes, that's before. Thank you.
Okay, all right. Just a note, we within the direct service classifications, we do have all your mental health, and we also have the substance use disorder group alcohol and drug counselors there. We have licensed physicians, which can account for psychiatrists and the MD in the SUD delivery system. So just wanted to note that it's all to go into this sheet. Other questions? Well, if there's nothing else, Kelly or John, I could turn it back over to you, and we could end early. And I can also be available if there are other questions, or if you think of something after the meeting, I'd be happy to answer that and share it with everyone.
And will you be sending out this recording to all the people that were on that email list?
So yes, I'm going to get the recording after we're done. Please bear with me. It's the first time I've done it. I'm wondering if I'm going to have to try to reduce the file size because I know it's kind of a long meeting, but somehow we'll get it distributed. I know that it's not going to be feasible to send this via email. We'll find some other way to distribute it.
Awesome. Thank you so much, John.
All right. Well, I guess with that, we can conclude. And thank you in advance for taking the time to do this. Appreciate the insight that this can help provide.
And I just maybe as a follow-up, so it sounds like there was a question with regards to turnaround time. I heard Jim say, let's try to get them back in a week. And then in terms of submitting them, John, do you have a thought around centralizing, like where providers should send these surveys back?
At this point, at this point, I think with that kind of a turnaround, I would suggest that folks send it to me in a week. So that would be, I'll be back on next Wednesday. So that will work. And then I'll compile and send them through.
All right, so let's make sure any email we sent out, hopefully everybody has John's, he sent the survey out this morning. So you should have his email address. So
just a quick thing, sometimes what we've experienced in the past with large monitoring tool files is that they get blocked by somebody's firewall along the way, as if you send it to John. My suggestion is, John, you send an acknowledged email so they know that it got through.
Yeah, you bet. And if I don't send you one and you've sent it, please do. Yeah, let me know how. So having said that, because I am off I guess I'll probably just check emails sometime Monday or Tuesday. And if folks haven't gotten them, I'll get back to you then.
Thank you, everyone. Just want to make sure, just a last minute check, because we are scheduled till 11. Just want to make sure people, I appreciate the dialogue and the questions asked. Is there anything else that's burning? Mary, thank you, Mary.
I just wanted to confirm, because there was a lot of conversation about changes. What we have now from John, we can start working on, or is we're not expecting any changes to the template?
Yeah, I think that you could work on that.
Okay, thank you.
All right. Thank you all. We're learning together, and I appreciate you all.
Thanks, everyone.
Thank you.
Here.
Bye.
Bye.